Metachromatic leukodystrophy, also known as MLD. Please note that the information in this slide presentation is up to date as of March 2020. What is MLD? Metachromatic leukodystrophy is a leukodystrophy in which sulfatides are not broken down properly. Sulfatides are lipids, or fats that contain sulfate and are found throughout the body, mostly in our nervous tissue, kidneys, and testes. When sulfatides accumulate in the nervous system, they can cause breakdown of myelin, also known as demyelination. MLD is caused by a mutation in the ARSA gene. The ARSA gene is responsible for making the aryl sulfatase A enzyme. A change in this gene causes the inability to make ARSA, which leads to improper breakdowns of sulfatides. ARSA is located in the lysosome and also referred to as sulfatide sulfatase. Lysosomes are organelles within our cells, also known as the recycling center. There are generally three types of MLD: late infantile, juvenile onset, and adult onset. I will go into all three of these in more detail in a later slide. How do you get MLD? MLD is an autosomal recessive neurodegenerative disease. The child can only inherit the disease when both parents carry the mutation. That means that the child has a 25% chance of inheriting the disease when both parents are carriers, and this holds true for each pregnancy. De novo mutations can also occur, but this is much more rare. Pseudodeficiency means that the individual has a mutation, but it is not a disease-causing mutation. Most common mutations are found in the ARSA gene. Less common are mutations in the PSAP gene. What are some of the initial symptoms of MLD? Late infantile MLD usually presents between 6 months to 2 years of life, and it may present with regression of previously attained milestones such as loss of speech, mobility, and motor skills. Other symptoms may include weakness, hypotonia, gait abnormalities, feeding difficulties. They may initially present after an illness such as a respiratory virus. Seizures as a first sign are less common but can occur. Juvenile MLD usually begins between 4 years to 14 years of age, typically seen in the school-aged child. Initial symptoms may include learning issues, inattention, such as seen in ADHD, abnormal behaviors, psychiatric symptoms, gait difficulties, tremors, ataxia, and neuropathy are also common. The progression is similar but slower than the late infantile form. And finally, adult MLD usually occurs after puberty but may not occur till the 4th or 5th decade. Initial symptoms include school or job performance issues, emotional lability, inappropriate affect, psychiatric symptoms, and the course is variable with periods of relative stability, usually making it harder to diagnose initially. How does MLD affect the individual? MLD is a demyelinating disease of the central and peripheral nervous system, which results in loss of motor skills and intellectual disabilities. Symptomatology can be affected by age of onset. Some of the most common symptoms include delay in developmental milestones or regression of milestones. And again, should especially be noted with the late infantile form. Anytime a child attains a milestone and then loses it should warrant, further evaluation. Intellectual disability, change in muscle tone, initially low tone, also known as hypotonia, and then later high tone, which is hypertonia. Hearing and vision loss, seizures, feeding difficulties, gallbladder issues, gait problems, ataxia, incontinence, speech disorder, peripheral neuropathy, and remember, function can become increasingly difficult with time. How is MLD diagnosed? MLD is diagnosed through blood work. They'll look at the level of aerosulfatase A enzyme activity level in the blood, and then urine is sent for sulfatate levels to confirm the diagnosis if a child's enzyme level is in the deficient range that suspects that they may have a MLD diagnosis. Brain MRI, abnormal confluent areas of white matter changes may be seen. Genetic testing, and something that's not typically done but could be done is nerve or a brain biopsy. And again, this is rarely done given the advances in other laboratory technologies that we currently have today. Common differential diagnoses include multiple sulfatase deficiency and saposin B deficiency. Given that both of the above diagnoses have similar symptomology and abnormal changes in enzyme level similar to MLD, metabolic testing for all disorders of the differential may be ordered at the same time. Is there newborn screening for MLD? The answer is no. It's not currently on the recommended uniform screening panel, also known as RUSP. However, there is a pilot study in Washington currently that's ongoing to determine the best way to screen for MLD. Follow-up protocols for MLD, again, it's sending the urine for confirmatory diagnosis of sulfatite levels, a brain MRI to determine white matter irregularities, and the determination of disease severity and symptom management. Is there a treatment for MLD? Currently, there is no cure for MLD, but there are treatments for symptom manifestations. Hematopoietic stem cell transplantation and bone marrow transplant are one option for a child who is eligible. This matches with family members or other donors and is typically used for pre-symptomatic and early symptomatic juvenile or adult forms. Children with late infantile MLD are typically not a good candidate for transplantation. Cord blood transplantation can come from umbilical cord or cord blood banks. Both treatments add in healthy levels of enzyme to the body but cannot reverse the demyelination or damage that has already occurred. Gene therapy is ongoing, and enzyme replacement therapy has been tried in the past but has been problematic due to it not crossing the blood-brain barrier. Intrathecal delivery of enzyme replacement therapy is due to have a trial that starts soon. On this slide, it lists the various research and clinical trials that are currently going on as of March 2020. I do want to make note that it's important to always visit clinicaltrials.gov for the most up-to-date information. Medical issues. The clinical management of MLD is extremely important and needs to reflect what works best for that child and his or her family, since no two individuals with MLD are alike. It is ongoing as new problems or issues develop over time. It affects almost every system of the body. This includes, but is not limited to, respiratory. They may develop excessive drooling, poor airway clearance, respiratory insufficiency. Gastrointestinal. They may develop reflux, swallowing and feeding difficulties due to the decreased GI motility, constipation. Musculoskeletal, the management of tone, routine surveillance for hip and spine, and monitoring for contractures. Neurology, the development of seizures and appropriate treatment. Irritability due to the peripheral nerve disease. Infectious includes fever management, prevention of illnesses, and monitoring for urinary tract infections which may develop. Routine evaluation of vision and hearing. It's very important with an individual who has MLD to be in prevention mode. The goal is to have a proactive approach rather than reactive approach. This is essential and extremely important in preventing further complications and improving the individual's quality of life. Listed below is some of the Leukodystrophy Care Network centers and other centers in the United States with expertise in MLD. Family advocate organizations for MLD include Hunter's Hope, the Leukodystrophy Care Network, National Organization for Rare Diseases, Leukodystrophy Family Forum, MLD Foundation, and Believing for Briley. Resources for medical professionals. And finally, resources for families.